Sujatha.
Thank you, Dr. Suhas, for this wonderful opportunity. My talk is on fine-tuning cataract surgery results and tackling a dry eye. So there's a typical case of a 57-year-old male who comes to us with refractive, for a refractive multifocal IOL. Post-operatively, his vision is 6.5 N6, but patient is not happy. He's complaining of glare, halos, fluctuating vision, irritation, and watering. So the commonest things that we see after we explain to the patient that there's going to be some halos and starbursts around headlights, and it will get adapted. And also some of them have a significant glare. This is probably the commonest thing that we think of, that it should be the multifocal IOL which is the culprit. But no, why not dry eye after cataract surgery? Why not think that, why can't it be a dry eye? Because we know the first refractive surface of the eye is a tear film, and to maximize visual acuity, we must ensure that the tear film is healthy and not dysfunctional. There are several studies which have shown that the tear film breakup time after cataract surgery significantly drops and maintains the dropped position over a period of 2 to 3 months. And these are changes which are shown, post-operative changes in a non-dry eye group as well as in the dry eye group, pre-operatively to post-operative. There is a drop in all the OSDI scores. There is a drop in Schirmer's, there's a drop in T-BUT. So when you compare the pre and post-operative, there are several studies which have shown that the phacoemulsification cataract surgery is associated with the risk of dry eye. The symptoms a patient can complain of the foreign body sensation, irritation, discomfort, watering, and fluctuating vision, and sudden sharp pain in the eyes. So we always deal with aging population in a post-cataract surgery patient. They are most of them have a comorbid systemic disease like a hypertension or diabetes. They are already using topical drops like Predfort, and then corneal nerve is also cut during clear corneal surgery. And additionally, if you're doing LRA or astigmatic incisions, this could again be a contributing factor. So the pre-op evaluation should consist of first looking at the patient as a whole after taking a detailed history. Look for blepharitis, look for meibomian gland dysfunction, look at the corneal surface, look for SPKs, filaments, do a Schirmer's test. And in addition to this, take an OSDI score, do a Schirmer's, do a T-BUT, and also a strain to see the fluorescent in rose Bengal. A simple topography, doing an eye trace will tell you whether the patient has a dry eye or not, whether the corneal surface is affected. The other important tests that you can do are the tear lab osmolarity test, which measures the concentration of the electrolytes in the 50 microliter sample. The higher levels indicate aqueous tear deficiency. The other one is the RPS test, which is a very simple outpatient test, which detects the MMP9s in the tears, which again indicates that the patient has an inflammatory tears. So coming to all this, we have found that most of the studies have shown the majority of the leading cause of dry eye is an evaporative dry eye, and meibomian gland dysfunction is probably the most leading cause. So what happens in a meibomian gland dysfunction? There's first thickening of the meibum, then the sloughing of the cells within the glands, which again further reduce meibomian secretion and block the ducts further, which leads to an inflammation of the eyelids, bacterial proliferation, and contamination of the healthy tear film with toxins. So the various diagnostic machines have come now. They are called the tear film diagnostics from different companies. The most important thing that we have learned is to look at the lipid levels in the tears. This is called as interferometry, that you can see the color of the lipid layer varies depending upon the thickness, and you compare it with the normative data and find out how much lipid the patient has, and then from there you can go on, you can know that the patient has some amount of lipid deficiency, you know that the patient has some meibomian gland dysfunction. Looking at the NIBUT also helps because it will tell you how much of when you project a series of Meyers on the cornea, the distortion of the Meyers indicate how much of non-invasive tear film breakup time is there. Look at the tear meniscus, and most importantly, the meibography tells us the amount of meibomian glands which are available for secretion. See here you can see that the loss is about 10%, then this patient can be treated for meibomian gland dysfunction. But there are a lot of patients who have a total loss of meibomian glands. They are necrotic, they are either already atrophic, so the treatment may not work in these patients. Management, I think the most common thing that we advise is warm compress. Warm compress 3 times a day, at least for 10 minutes. Use of artificial tears, gels and ointment, anti-inflammatory drops, steroids, cyclosporin, using punctal plugs wherever required, use of omega-3 fatty acid and doxycycline. All these are the general management of a patient who has got a meibomian gland dysfunction, and you have to emphasize that the warm compress should always be done and every day at least 2 or 3 times a day. So coming to the newer modalities of treatment for meibomian gland dysfunction is the IPL, which is an intense pulse light device, which uses a high intensity source of light ranging from 550 nanometers to 1200 nanometers. And the treated areas, the eye is covered with a mask, and the treated areas in the malar area, that is along the cheeks, 5 shots are given, and the mode of action is the heat transfer is the one which happens, which softens the meibum and aids expression, and it thromboses of the abnormal vasculature, and this is what was first used in dermatology for rosacea patients, and which has been taken up in ophthalmology. And also this diminishes the local release of inflammatory mediators by taking care of the telangiectasis vessels, and thereby the bacterial load on the lid margin of the ocular adnexa could be directly affected by the IPL. So it also stimulates the zygomatic nerve and increases the production of meibum and equus. This is a small film which explains the whole thing. You can see that in the normal, when there is a meibomian gland dysfunction, there is no oil which is coming onto the tear surface. But by using a modality of IPL, which increases the meibomian gland function, I'll just show you how it is done. So these are the meibomian glands. You cover the surface of the cornea with a mask, and you apply a gel on the malar area and give 5 shots of IPL to the surface, and this stimulates the zygomatic nerve, also the parasympathetic nerves, which stimulate the lacrimal glands to secrete the tears, as well as reduces the telangiectasis. So the treatment intensity varies from 8 joules to 20 millijoules and depends upon what type of skin the patient has. The darker the skin, they use less. So patients with contact lens where any other eye surgeries or precancerous lesions should be avoided. Also patients with immunosuppressive disease or patients who are on doxycycline or using any skin ointments should be avoided. So there are a lot of trials which have shown that the results are excellent. So the LipiFlow uses a different technology, is a vector thermal pulse technology. It delivers heat and has a therapeutic motion regulated with sensors. So it's basically like a large paper clip which is applied to the lid, and there is an application of heat at the same time. There is a continuous pressure which is going on. So this opens up the meibomian glands, and the obstructed meibum is liquefied and expressed. So this resumes producing and delivering the essential oil needed for the healthy tear film. So this is, you can see that I don't have so you can see this, there is an eye cup over the cornea to protect the warmth from going inside, and there is a rigid cup and an inflatable air bladder which keeps pressing on the lid. So basically it has got an action of not only giving heat, but also that is because of the air bladder, it keeps pressing on the lid, and it gives a motion of expression of the meibomian secretions. The entire treatment is only for about 12 minutes, but the results, they say, last for about a year. So these are various studies which have shown that the restoration of meibomian gland function post-LipiFlow treatment is excellent, and the patient has regained the normal tear film on ocular surface. So the Tixel is the new technology which has come in. I don't think it is commercially available yet in India. Again, this is taken off from dermatology machine. This is a non-radiation technology which has got a highly controlled adjustable direct heating. The advantage is that it directly sits on the lids. So you can place it, the tips can be placed on the lids. So it's a combination of giving heat as well as a small puncture. But the puncture does not penetrate the skin, but it just puts a pressure. And both superior and inferior lids can be treated, and about 20 pulses per eye in less than 1 minute is done. So this is a very small portable machine. It can be taken to the patient's office, and it's very innovative because it's something which has been was used for treatment of wrinkles, skin folds, creases, and they found that it worked very well when they were treating the wrinkles along the lid margins. They found that the effect for meibomian gland disease was also very good, and so this has been included in ophthalmology. So the benefit of Tixel is it does not emit radiation, it does not present any eye safety hazards, it has a titanium tip which is durable. So coming to, it does not perforate any tissue, no bleeding is there. There could be a minimal pain because of the puncture which happens during the treatment, but ultimately it works very well. So just to summarize, I would like to emphasize on the 3 new technologies which have come, the IPL, LipiFlow and Tixel, which helps the meibomian gland dysfunction, in addition to whatever you will be doing like warm compress and lubricating drops. So summarizing, pre-op evaluation of borderline dry eye patients is very important for management to make a life a lot easier for the patient, because if you don't diagnose them, then you're going to land up with a problem with a very unhappy patient. So it's important that you manage them pre-operatively before you take them up for cataract surgery. Thank you.
So much, Sujatha. It's an extremely important, and thank you also for touching on all the newer modalities that can be used for managing dry eye. With this, we come to next, the most important surgical topic. Now, when it comes to choosing a lens for fine-tuning cataract surgical results, the number 1 product is a toric lens. Now, toric lens is one where there is no downside. You know, if you're accurate, it works wonders. If you're not, it doesn't really, downgrade your surgical results. And with that, we know that someday toric lens is going to practically take up 35–40% of our practice. And with that in mind, I have Dr. Zain Khatib, a young ophthalmologist who would be, touching on this topic. Dr. Zain.
Good afternoon.